Monday, November 16th. It's with heavy heart that, of course, we have over the tragedy in Paris the other day. And again, we hope that that's the last we hear of those type of tragedies. We're very lucky today to have sort of a confluence of panel who are really expert in a topic. Each and every one of them really happened to be able to lend a lot to the value of this topic, and I think it's going to be a very dynamic and exciting panel discussion. As our visiting professor today, Joseph Rodes-Cabou from Quebec, actually trained part of his career in Paris. The moderator today is going to be Dr. Sharma, who's Director of Clinical Interventional Cardiology, President of Mount Sinai Heart Network, Dean Interventional Clinical Affiliations of Mount Sinai Heart. Coincidentally, one of the panelists, who's usually the moderator, has been the editor of the journal in which many of Dr. Rodes-Cabou's seminal papers on this topic of transcatheter valvular intervention have appeared. Dr. Valentin Fuster, besides being editor of JACC, is director of Mount Sinai Heart and physician-in-chief of Mount Sinai Hospital. Dr. Ray Beatry is assistant professor of medicine, specializing in heart failure. Dr. Dangus is professor of medicine and director of cardiovascular innovation. Also on the panel is Dr. Anu Kinney, professor of medicine, director of structural heart intervention, director of cardiac catheterization laboratory, and director of interventional cardiology fellowship program. Dr. Sen Gupta is associate professor of medicine, director of cardiac ultrasound research in Core Lab, and accompanies the interventionalists in management of these patients in both the cath lab and deciding about the pre-procedure intervention. Dr. Stelzer is co-director of the Heart Valve Center, senior faculty in Department of Cardiothoracic Surgery, a pioneer in cardiothoracic surgery, particularly in the Ross procedure. And last but certainly not least is a fellow who's done a very, very good job in putting together a monograph. And I'm going to ask Samir Sheth to give us overview on this topic, which is transcatheter mitral valvular intervention, though the topic from the moderator, Dr. Sharma, is going to include tricuspid as well.
Good afternoon. I would like to start by thanking our guest, Dr. Rodes-Cabou, for a great day. We had a great lecture on therapies for heart failure. We had a lunch, and then we actually ran some cases by him, which the fellows really enjoyed. So thank you again. I'll also thank Dr. Fuster, Dr. Goldman, Dr. Sharma, and the entire panel today for the opportunity to sit and discuss this topic with you all. Transcatheter therapies for valvular heart disease have become an exciting topic. As the population ages, the number of older, sicker patients with symptomatic valvular disease will continue to rise. While operative repair is the standard of care, increasingly patients are too high risk and not deemed optimal candidates for surgery. Transcatheter valve replacement is emerging as a new option for the treatment of mitral and tricuspid valve disease. Severe mitral regurgitation represents the second most prevalent valvular pathology behind aortic stenosis. Over the last few decades, our understanding of mitral regurgitation as a clinical and pathological entity has grown immensely. The complexity of the mitral valve apparatus and its relationship with the left ventricle make the development of novel devices challenging. The mitral valve annulus is a dynamic, D-shaped orifice. In comparison, the aortic valve is a less dynamic, more circular valve, allowing easier positioning of a transcatheter device due to heavy calcification that allows for tethering of the outer stent. When discussing mitral regurgitation, it is important to distinguish between primary mitral regurgitation caused by myxomatous degeneration and prolapse versus secondary or functional mitral regurgitation, most often due to myocardial infarction or cardiomyopathy. This is critical because we know the mortality benefit associated with surgery for primary disease, while currently there is no mortality benefit for the treatment of secondary mitral regurgitation. This highlights the difference between the treatment of a dysfunctional valve alone in comparison to a valve with an unhealthy ventricle. there is much debate about the appropriate therapy for ischemic mitral regurgitation. The standard of care has been medical management, and recent trials examining coronary artery bypass surgery alone or with mitral valve repair have showed no difference in a surrogate primary endpoint. We must consider what outcomes to examine with new transcatheter therapies when mortality cannot be directly compared. Reduction in symptoms, hospitalizations, or improved quality of life measures may be better surrogate outcomes. As we begin to examine the role of new transcatheter therapies, non-invasive imaging will be essential for the evaluation of etiology, mechanism, and severity of mitral regurgitation. Transthoracic and transesophageal echocardiography, as well as intracardiac echocardiography, cardiac magnetic resonance imaging, and multi-detector row computed tomography will be important in procedural success. A current FDA-approved device is the MitraClip, a transvenous, transseptal, edge-to-edge repair system for the treatment of severe degenerative and functional mitral regurgitation for those patients at high surgical risk. The Everest and Everest II trials have shown it to be a safe and feasible option compared to mitral valve surgery in this subgroup. There are a large number of transcatheter mitral valve repair devices currently being developed. 4 devices with preliminary reported outcomes in humans include the CardioAQ, Tiara, Tendyne, and Fortis valves. Each valve has a distinct profile and delivery system, but most consist of a nitinol frame around a bovine pericardial valve, which is delivered transapically and anchored to the native mitral valve leaflets. Clinical experiences with a small number of patients using the Fortis valve have shown improvements in functional status, exercise capacity, and quality of life. Other small trials have examined mitral valve-in-valve procedures for patients at high risk of reauthorization using the Edwards Sapien XT valve. While used in the pediatric population, tricuspid valve-in-valve procedures are in a preliminary phase in adults with functional regurgitation, but early experiences have shown improvement in functional status. Other transcatheter procedures, such as coronary sinus annuloplasty, have not been promising secondary to technical difficulties stemming from distortion of the mitral valve leaflets and annular anatomy. As transcatheter mitral valve technologies and different approaches evolve, there are a number of clinical and technical challenges emerging. Physicians must take into account the mitral anatomy, clinical status, surgical risk, while working in multidisciplinary teams to find the appropriate therapy for each individual. Currently, there are an abundance of new devices being developed, and there's a need for a well-designed, randomized clinical trial to examine the safety and efficacy of the growing technology. Thank you.
Okay, thank you, Samir. Very exciting subject, isn't it? All the young people are very excited. The more senior people are cautious. Anyway, it's a pleasure to introduce today Josep Rodés Cabau. It's a double pleasure. He was born where I was born, in Catalonia, in the north of Catalonia, in Lérida. And he has a very exciting curriculum, very pragmatic person, actually. He got the extraordinary prize as a student at the university. In Spain, at the moment you finish the medical school, there is an exam, and 20,000 people take the exam, and they rated them, and he was number 18. Number 18 out of 20,000 is not bad, isn't it? So he got the PhD thesis, he got the outstanding degree, and then he became a resident in cardiology in one of the hospitals in Barcelona, and then he moved into the interventional field, actually at the Montreal Heart Institute, and he was a fellow there. And then he was a fellow in interventional pediatric cardiology, also in Lille, in France, where is a very important group of interventionalists. Well, he became a staff member in Quebec, at the Quebec Heart Institute in 2003. And then at that time, he was named Director of Interventional Adult Congenital Heart Disease, subsequent Director of Interventional Structural Heart Disease, eventually Director of the Catheterization and Interventional Laboratory, and at the present time is a Professor of Medicine at Laval University in Quebec. He He has accomplished a lot over a short period of time. Actually, he is the advisor at the FDA on transcatheter aortic valve programs in the United States. He's a member of the Valve Academic Research Consortium. People know is BARC2 and BARC3. And then he's a principal investigator of the Canadian Transcatheter Aortic Valve Replacement Registry, they call SOURCE Canada. And certainly he's an associate editor of the Journal of the American College of Cardiology. He has achieved all of this in a very short period of time. Now, short period of time, but certainly in his curriculum, the number of publications are already close to 300, and the publications are really all aspects of cardiovascular diseases, actually, but particularly in the interventional field. I always like to look at the first publication. I don't know if he was misguided, but the title of the first publication was in the Annals of Internal Medicine in 1992, Pustular Arthrosteitis, Diagnostic Difficulty in the Initial Stages. I don't know where your head was at that time, but I hope people were able to guide you subsequently in the right direction. Well, I think this is probably one of the youngest visiting professors here over the last few years, but certainly in a short period of time, I must tell you, he has accomplished a lot. So, Josep, welcome to Mount Sinai, and let me give you this plaque to remember us. And all right. So all the beginning is that we are very happy to have you here. And the end is the Anandi Sharma visiting professor, the Simon Doug Memorial Lecturer, November 16, 2015. So this is for you. Put it here. Okay, so now I'm going to ask the panelists. You can sit in the middle. And I'm going to ask the panelists, lots of panelists, so I am going to take a vacation today. Let me sit there. Raymond Bitri, George Dangas, Anu Kini, Arthur Sengupta, Paul Stelzer, and Samir Shit. Okay? So you are good, all of you here, so I'm going to take a rest.
We need our echo, but everyone is here. After saying Dr. Fuchs is taking rest today. Well, it just tells you that the topic clearly is, I would say, maybe a little unusual, but the focus by Dr. Fuster is to pick up the best and the latest in the field and discuss about. And today we have, in the past, we have discussed quite a bit about the aortic, and main discussion will be today about the transcatheter mitral valve replacement, implantation, and of course we'll pay maybe last 5-10 minutes about the tricuspid. Purpose is just to bring everybody up to speed where we are in terms of the tricuspid valvular intervention. With that note, Dr. Cabal, we really welcome you, and of course with all the panelists. The way this evening will go is that some of the questions will be asked to you and other panelists and take your opinion. Because all of us need to learn from your knowledge, from your experience in this particular field, and then some case scenario where mitral valve percutaneously will fit in. So we have all the experts, both surgical, non-surgical, interventional, clinical, and so on and so forth. So just, I think we go step by step as the total, taken the whole mitral space and field. One is about the history. The statement made that almost 10% of the people over age of 75 will have a significant mitral regurgitation, and some studies have shown that almost 2 million people in the United States suffer from severe mitral regurgitation. You think it's a true statement? Because 2 million is a lot of patients. 2 million severe mitral regurgitation or significant mitral regurgitation.
Honestly, I'm not an expert in this epidemiology aspect. Maybe the heart failure specialists can answer this question specifically in US. But the prevalence of the disease in older people is definitely very high.
Because I used to think the aortic valve disease, and there we make maximum number of patients being 200,000 in the United States, and talking about a 2 million to me it looks quite high. And of course, some of the paper, maybe the Raymond, B3, you want to comment on it, truly?
I saw the same numbers quoted as 2 million. Beyond that, though, I think as we talk about the prevalence of functional mitral regurgitation and the changes that take place in the heart over time, it's not surprising to see associated significant functional mitral regurgitation. And I think in our clinical practice, we routinely see, as we have an advancing population with heart failure, you see with that significant mitral regurgitation, which does occur in the setting of this adverse remodeling that takes place. So the actual number, I see the same quote, but in clinical practice, it doesn't surprise me to see such a high prevalence.
So actually, the data comes from two. There's a difference in the population-based study from Europe and in US. The US, the data has come from Olmsted County by Anokmo and colleagues in Lancet, where they looked at the prevalence of, and the largest prevalence was seen with degenerative mitral regurgitation in that study. And I think the number, I don't remember exactly, but like 4% to 5% above the age of 75 had mitral regurgitation as the number one, followed by aortic stenosis. Whereas the EuroHeart study from Europe, which was actually from a tertiary care center, multiple tertiary care centers, not population-based, their aortic stenosis was the number one. So these are the two studies which are often quoted in the literature.
Actually, we can hear from Dr. Stelger also on this particular the field in terms of the extent prevalence of mitral regurgitation.
Well, I think they're exactly saying the right things. I mean, as the population ages, we're not just seeing aortic stenosis, we're seeing mitral regurgitation too. And there's a certain sluggish progress of this disease, shall we say, through life. The patients go for years and years with a diagnosis of mitral valve prolapse without regurgitation. Then they get a little regurgitation. Some of them are discovered to have had a bicuspid aortic valve all along because that click wasn't MVP. But the ones with mitral valve prolapse, many of them will develop further disease when they get over, 75 is this estimate that so many people are going to have it. And I think there's not a minor correlation between the estimate of 80-year-olds, at least 10% of those people are going to have atrial fibrillation. Well, why should that be? Well, there's probably a correlation that these two diseases are going hand in hand. It's not just isolated atrial fib in this 10% and mitral regurgitation in the different 10%. I expect there's a big overlap between those.
Okay, so it seems to be that, yes, they're quite common. And of course, as mentioned, the two types, one primary or secondary, or we call it degenerative or functional regurgitation. And of course, both of them have a different prognosis. I think for the purpose of our discussion, we just not go into details about one versus other. Clearly, the focus will be a little different. But in terms of the overall, now the patient has a mitral regurgitation. The question all has been that whether which patient gets to surgery or patient get intervention for that matter. And maybe I can just open this for a brief one-liner statement from all our panelists that which patient of the mitral regurgitation they feel that now you need to go beyond just doing medical therapy or just observation, and the patient should get some intervention. So with that, knowing Samir has done a tremendous work of reading this literature. So question is, what degree of mitral regurgitation, when do you think about that we should go further just besides following the patient or managing them conservatively?
So I think the guidelines would tell us that For primary mitral regurgitation, there are indications for surgery, and if a patient is a surgical candidate. And we have different scores that we use, whether the STS score or the Euro score, for assessing surgical risk once they meet the criteria for primary mitral regurgitation, whether it's new atrial fibrillation, reduction in ejection fraction, and symptoms, basically, in an asymptomatic population versus symptomatic population. I think the controversy or the debate comes in whether we start discussing secondary mitral regurgitation. What are the characteristics we're looking for when to operate on these patients? Right now, we do not have great data on the utility of surgical repair in this population, and I think what we're trying to do is what we're trying to assess is symptomatic relief with repair of the mitral valve, and then other surrogate endpoints, which we can talk about later. But I think the controversy is going to center around this secondary mitral regurgitation.
Okay, Dr. Kabar, you want to add anything on this? Particularly the issue that always will come, that at what level of the regurgitation? We know that for the degenerative mitral regurgitation, everyone knows whether there is whole guidelines in terms of whether they're asymptomatic, exercise induced, pressure goes up, and so on and so forth. So a question that comes is it now increasingly accepted by the community that even degenerative asymptomatic mitral regurgitation should be fixed? Of course, by and large will be surgically. What is your opinion on the asymptomatic, the severe mitral regurgitation and degenerative?
I think that there are several studies showing really that an early intervention may have an impact on the better outcomes in these patients. I think a lot of this work came from the Mayo Clinic group, showing this the importance of an early intervention in many of these patients. But I agree that the important question will be about these secondary mitral regurgitation patients that we are treating more and more with transcatheter techniques without having, in fact, a very good knowledge about the efficacy of treating this particular disease in this context. I think that this will be the question that needs to be answered, probably with the trials that are ongoing about the treatment, even if it's less invasive, whether or not will be efficient for these patients, especially improving outcomes in these patients is not known yet.
And actually, that's a very interesting point, because the studies, there was one randomized trial of 200 plus patients, CABG versus CABG plus MVR in patients with mitral regurgitation, and there was no clear-cut benefit. But more important comes back to, and this question is to Raymond Beatry, is that when they're treating the patients with heart failure, many of them had 2+, 3+, or 4+ mitral regurgitation. And when does comes in mind that let's think about doing something in those cases? Because when we are treating patients with a functional or regurgitation, treatment, everybody's thinking is just maximum medical therapy. So when does, in your clinical practice, the point comes that, you know what, let's go beyond just the medical therapy in these cases?
Currently, my answer is rarely. But let me just first reinforce the extent of medical therapy that I think is necessary to exhaust before you consider these advanced processes. So, from the get-go, we're talking about a disease process that is secondary to a remodeling and dysfunctional myocardium and left ventricle. And so I think that, any intervention that can be done to help in terms of promote appropriate positive LV remodeling is going to have a hopeful effect of reducing the severity of the mitral regurgitation. So that includes effective diuresis, very effective diuresis. That includes neurohormonal antagonists that are going to be escalated. That includes CRT if otherwise clinically indicated. all of these interventions have to be exhausted from the get-go, because at the end of the day, it still remains largely unclear whether or not revising the mitral valve is going to affect and improve in the LV. And what we know is that this is largely a disease of a dilated and congested left ventricle. And we also know that in those patients, not only by the presence of mitral regurgitation, but by the presence of persistent congestion, we know that they're a very poor cohort with a poor adverse short-term and long-term intermediate and long-term outcome. And so very often, in the absence of exhausting all of those other options, my next question as a heart failure cardiologist is more along the lines of whether this is a patient for advanced therapies, including left ventricular assist devices, rather than necessarily moving to mitral valve repair. I would say that right now, in my current clinical practice, investigation of intervention to the mitral valve is usually considered for me when I've maximized medical therapy as I've described, as well, and felt that the patient is not a candidate for advanced therapies.
So therefore, I think it's the clear message that particularly patients with the functional mitral regurgitation, the treatment still remains the maximum with the medical therapy, and then, or the thought on the side of assist devices once it becomes very progressive. That may be reason that many of these patients continue, because that's the difference than the aortic stenosis, even with the severe LV dysfunction. We know that in that case, you fix the valve, majority of the time, everything else settles. Of course, if there is a comorbid condition, limit the lifespan is a different story. With the mitral regurgitation, and particularly functional variety has gone down to the severe LV dysfunction, the things are very complex. So mitral valve alone becomes a very, or not the best target, because it requires more than that overall. So now coming back to the treatment, then of course the surgical treatment we need not to discuss for today's our discussion. We need to concentrate on the non-surgical treatment, because Sinai being one of the premier mitral valve center, where 99+% cases are done with a mitral valve repair, whether it's a repair replacement, all has been questionable, as you know. This year has come into discussion, one technique versus the other, so plus minus benefit of in some of the trials of repair. But key question then comes back is that what are the cases and who is the suitable candidate for non-surgical replacement or repair of the mitral valve. So with that note, maybe we'll ask George now about the basis of the Everest trials.
This was a very pioneer study, the Everest trial, in that it was a little bit beyond its time. Recall, everyone knows the TAVI trials, we started from inoperable patients and then marching back to severe, high risk, then medium risk, and then later on maybe even low risk. We see about that. But that was the flow. In the Everest, there was a completely different approach. They went right ahead in a randomization against surgery in patients who obviously could have surgery. And they aimed to show that a reasonable job could be done with a clip in patients with fewer complications, and they capitalized, of course, on the fact that the surgery includes cardiopulmonary bypass, extensive transfusions, respiratory complications, all sorts of things that happen with surgery. And a little bit of the drawback of the study ultimately was that the endpoint was understandable. Patients did have fewer complications with a clip, definitely. On the other hand, the result, the efficacy wasn't exactly there, and in the fact that about a significant number of patients, about 20% or so, they ended up with an imperfect result with use of the clip with significant residual MR, whereas a lot of criticisms came about from the surgeons that do this a lot, that in their hands, the MR should not be more than 0 to 1 plus, and they would consider a 2 plus sort of a failure. At the same time, though, the Everest does have a very long follow-up and answers some very important questions. Is a clip durable when we put it, or does it fly away? It is durable. Could a valve, after a clip, for whatever reason, needs repeat surgery, could that be done safely? Definitely yes. And if the patients who have an initially good response, do they erode over time? The answer, no. So all these three things also need to be known and are very big lessons from the Everest trial. What it hasn't come up is that the Everest was not really in inoperable patients, and that's where this device had a problem with the FDA that made them go back to square one and try to figure out what to do in inoperable patients that really not extensive data exist. And they try to patch that with registries and hodgepodge from Europe, etc. And that's how we use it right now. And I think due to the lack of organized data, as in the TAVI, this field has been a little bit behind in development.
Now, Dr. Kebab, you are very much involved very early with the mitral clip. So maybe you can tell our audience your early experience and where you feel fit in. At present, one of the part of the mitral valve replacement, which is the mitral clip going through the Everest and then approval and so. So just share your experience and real clinical utility of the device.
I think that I agree with George that the problem with the Everest was trying really a percutaneous technique like the mitral clip that it mimics a very simple surgical intervention that is really not applied while trying to compete with surgical repair, especially in institutions with a lot of experience. Was obvious that we could have never win or be non-inferior to surgery. What means that the principal indication for the mitral clip nowadays, and this was at least also from the very beginning, at least in Canada, and I think in Europe also, are those patients considered to have an indication for mitral repair and having a very high surgical risk or prohibitive surgical risk for mitral valve surgery. These are the type of patients I think that we are treating. Most of them with degenerative mitral regurgitation, but as it occurred also in Everest, there were patients with functional MR that were treated. And there are patients in our daily life with the mitral clip with functional MR that are being treated. And again, I agree that in these type of patients, sometimes the clinical decision of the time where we should treat these patients and the clinical indication is controversial many times. These type of patients are discussed in weekly meetings with the mitral team, with surgeons, heart failure specialists, and it's difficult to get a consensus about which patients might benefit or not from the mitral clip therapy. The advantage with mitral clip thought is that the rate of peri-procedural complications is low. Is relatively low, unlike maybe other new valve platforms, even if are percutaneous. I think that is an acceptable risk, and then sometimes there are patients where we don't have a clear consensus where we try the mitral clip in order to see whether these improve symptoms.
Now, Anu, Dr. Kini now, comment on, do you think the mitral clip is effective device?
I don't know, what should I say? I think listening to all the people that who have just mentioned, George's comment as especially why TAVR actually took off and mitral clip is still in stages where even in the top institution, many patients are not getting this device. I think compared to TAVR, this definitely is a technically very challenging procedure because interventionalists are used to what is called as fluoroscopy, a different way of looking at the whole heart, and we need to train ourselves to look at echoes, three-dimensional views as well as 3D echoes, and then understand how to repair the valve by using a clip. But cases that we have done, we definitely have seen, this is again going back to patients who are real symptomatic, 4+ mitral regurgitation. If done the right way, you definitely see tremendous change with the complete obliteration of mitral regurgitation and decrease in PA pressures as well as obliteration of the V waves. So I think in selected cases, this is very important that you select the right patients, and the procedure definitely works, and you see the patient definitely a change in their symptoms.
Yeah, just to update everyone, the mitral clip about 2 years ago got approval by the FDA based on the trials of Everest, which you mentioned. Everest was the early one, then Everest 2 was the randomized trial, which was briefly alluded, 270 patients, 2-to-1 randomization, low risk, who could go for mitral valve repair, or surgery actually, mitral valve surgery, 2-to-1 randomization, 184 versus 90, and they included about 25% functional mitral regurgitation. And after the clip, and these are the people who are already very selected center, 12 centers or so, the trials were done, and those were already expert in putting the clip, and which the failure of the clip, I would say, counted as more than 2 plus residual mitral regurgitation was almost 18-20% of the time. But safety-wise, device was successful, and of course, the patients who probably left with a significant regurgitation or still residual, 2-3 required surgery, and that number was about 20%. So 20% patients in the clip group require mitral valve surgery in first year, and compared to 1 or 2% in the surgical group for some reason. But after 1 year, the difference, further subsequent treatment for mitral valve or surgery was 2 to 3% in each group. Dr. Cabo, you want to comment on this?
Yeah, the increase in the rate of recurrent mitral regurgitation in the mitral group was more important, and at this point, when you are really like sending the patient to surgery after a while, when you have implanted the mitral clip, this can be a very complex surgery, meaning that in many patients now that are those patients who could be operated on but have a high surgical risk. Our strategy is we can do the mitral clip procedure, but then we reevaluate the patient very rapidly to see the efficacy or the degree of reduction in mitral regurgitation. And if we are not satisfied, then we operate on the patient, but very rapidly, in order to avoid all the fibrotic process, etc. Meaning within the 3 months of performing the procedure, the patient gets a second evaluation by imaging. And if we consider that the result was not optimal, then we send the patient for surgery in these borderline cases or high-risk cases, but still operable.
Yeah, and actually that's come back to the question that while we know the clear answer in an extreme risk, high risk aortic stenosis patient, when the both devices means surgery and TAVR have been studied and the result, it will be unlikely that we'll ever see a trial in a high risk patients surgery against clip. Maybe it could be the surgery against the mitral valve complete replacement. You agree with that statement?
Yeah, I think so. And the problem also is, unlike TAVR, I think that, and Everest showed in terms of safety, it is clear that a mitral clip is a safer procedure as compared to surgery. Even in TAVR, you have some complications that are more frequent with the transcatheter therapy versus surgery and vice versa. But here, really, the technique in good hands, in experienced centers, is quite a safe procedure. And it will be very difficult for surgery to beat this safety aspect with mitral clip in high-risk patients. Then efficacy is another thing. But I think I agree with you that it will be difficult to run a trial in real high-risk patients, as we did with the TAVR procedures.
Yes, following the Everest trial original publication, many subgroups from the Everest which were high risk, and subsequently others, they continue the realism registry, putting a clip in patients who are surgically inoperable, high risk patients, and they just have a longitudinal follow-up, and they compared based on those STS risk with the Duke's established risk of those patients, and found that by putting a clip, you decrease the mortality by 50%. So that led to all these data, and of course, a lot of data from the Europe came, and that presented to the FDA, so that then FDA approved the device for degenerative mitral regurgitation. So for the primary, patients who are high surgical risk. So surgeon clearly had to attest to it, that is a high surgical, not going for surgery, and for which the device is approved at present from the CMS perspective. Now, for the functional regurgitation, functional actually, while there was a clear-cut benefit in the average trial of the valve surgery over mitral clip in the degenerative group, which was a 75%. In the average trial I mentioned, it was a low-risk group. 25% were the functional. There actually both trial had, again, a small number of cases, but there was no clear-cut difference, and that has led to now continuation of 2 trials, one in the United States, one outside, for functional mitral regurgitation, who are refractory to medical therapy. So it's a very complex process of involvement, and that patients have to have multiple treatment with the heart failure team and adjustment of medications. You have to repeat the echocardiogram, have to have 3 to 4 plus mitral regurgitation, and then they're randomized to clip or continuation of medical therapy. So it's a tough time. They're supposed to do about 400 cases. The trial called co-opt in the United States, outside the reshape, but the United States 400 plus cases. The trial is ongoing for 4 years, and we have just done 300 plus cases. Just because it's very tough to find. I mean, we had 3 patients at Mount Sinai, and of course, one of the things which we found, that once patients under strict surveillance, you change their medication and you bring them back for follow-up echo. Biggest exclusion is the mitral regurgitation become less than 3, or effective regurgitant orifice area of 4, and so it becomes less. And therefore now they're not suitable for to be enrolled in the trial. So this is really, we are seeing the patients tough time to enrolling into the trial. So overall, to sum up from the clip perspective, so that's the only clinically proven device, or approved device, I would say. May not be that effective, but in refractory patients or high-risk patients with the severe mitral regurgitation will decrease the regurgitation in majority. About 20% of cases still will have 2 plus mitral regurgitation, but hopefully with the medicine, you can bridge the gap and so. Now, Partha, you have been involved in all cases at Sinai. You want to tell us what is our the incidence or your echo findings of the mitral regurgitation post-clip?
Yes, so I think the cases of clip that we have done, and as correctly pointed out, the selection is very important. So this degenerative mitral regurgitation, you have to really look into the central MR, A2, P2 segment involvement, and if you are carefully selecting this patient, avoiding wide gaps of mitral regurgitation and wide gaps of heights of prolapse, carefully selecting. I think we have been very, with precise positioning, with 3D echo guidance, been able to bring down out of the 6 or 7 cases that we have done. I think we left 1 plus 2 plus regurgitation in handful of cases. So it's been very, very effective once done with the 3D echo guidance. And I think it's been a learning curve also. Selecting the patients and doing the procedure together in the cath lab. I just wanted to bring in one question, and we always talk about this functional regurgitation, and once we give the medications, it comes down. But functional regurgitation is extremely dynamic. If I exercise that patient will develop severe mitral regurgitation, and I don't think the trials are addressing that adequately, because what becomes from 3 plus, 4 plus with medication to 2 plus doesn't mean that patient is not having severe MR. That patient can start running and have develop severe MR. Absolutely. And we are not addressing that. And I think that at some point someone will bring up is the limitation of the current COAPT trial.
It's a very interesting point. We do more and more stress echoes in patients with mitral regurgitation, where we have serious questions about the severity, and as you said, it's very frequent to see how the significant increase in mitral regurgitation, in pulmonary hypertension during exercise in many of these patients. And in the clinical decision process, I think that these stress echoes are becoming more and more important. This was a concept that was, I think, initially came from some European centers, but is now being adapted by many, at least our centers.
Yeah, at least we do in cath lab also. We do dynamic exercise and they start developing severe MR and PA pressure goes up. So I think the functional MR, although we are trying to address in the trials in a very limited way, it's a very complex process. There are multiple factors and the severity is very dynamic. Something which is moderate today can tomorrow be severe. And it all goes by the patient's symptomatology. If the patient is clinically not behaving well, whatever the echo says, it has gone down, or I think we have to push down the patient for a stress echo or something and correlate. I just wanted to make that point that I think it's a very simplistic approach.
Now, Anu, you want to comment on this exercise in the cath lab about looking at the degree of mitral regurgitation and need for some intervention?
I mean, this is a question that always comes up, that echocardiogram, the one patient has presented with heart failure somewhere, echocardiogram done outside, or found that patient had moderate to severe mitral regurgitation, and patient is on good medical therapy. Then patient is sent to rule out CAD or evaluate the mitral regurgitation. So when they are in the lab, of course under sedation and now under medication, what happens is you actually see the PA pressures probably near normal. You're talking about mean just about 30 or so. And if the CAD is ruled out, and there comes the equation, does this patient has one symptom or a couple of episodes of heart failure symptom, that is this the patient that should go for surgery? Since right now PA pressures are normal, and this is the kind of patient that we can exercise in the lab, or like I don't know, you do the stress echo. Yes. So few of the cases we have done together, that he does echo and we exercise the patient. And the guidelines are always for patient with mitral stenosis, that if you have mitral stenosis, if you exercise the patient in the lab, we can use the same criteria to evaluate even mitral regurgitation, that if your PA pressure goes above 60, and this is the kind of patient that if we do an LV gram at that time, we have seen that patient has severe mitral regurgitation. Either if it's eccentric jet, we just have to do another view. But a couple of patients that we have done together is that these kind of cases, when he's doing echo in the lab at the same time with exercise, we definitely see increase in mitral regurgitation. But I think the key thing is that PA pressure, which was normal when the patient was just started, changes with the exercise. And it's not that they have to do a lot of exercise. Just with the dumbbells in the hand, few times they go up and down. If it is severe MR, you immediately see the changes in the PA pressure. And these kind of patients are the ones who definitely will benefit from intervention, whether it is surgery or in selected cases, maybe mitral percutaneous clip.
Yeah, I mean, clip is still need to be seen for those patients we are trying to establish as such in the regular cases. And so now question comes is that, Dr. Kaval, what your prediction? You think the mitral clip maybe make some changes, because things we know that just to say for the TAVR valve, in last 5 years since approval, each design has changed to a 4th generation now. So what started 5 years ago or 7 years ago when the trials were done, now we are talking about the 4th generation device, which will decrease the sheath size, the placement of the device, you can place it, you can retrieve it if it's not the right place, and so on and so forth. Classical example, sheath size which used to be 24 French, that almost 8 millimeter has now become 14 French, barely 5 millimeters, so significant improvement. So anything, because knowing that the total valve replacement is still far away, that anything which we coming in the horizon in terms of the mitral just repair point of view, percutaneous repair?
In the percutaneous repair, I don't see really, or I'm not aware about major changes in the mitral clip system. Again, probably there has not been major safety issues as it happened in the TAVR field with vascular complications, etc. And maybe there is no major interest to invest to improve a system that in terms of safety it goes quite well, and probably in terms of efficacy it could be very difficult to make major changes. The major players, apart from the mitral clip, which is like the edge-to-edge repair, are all the annuloplasty devices that are there. At the very beginning, we started with these indirect annuloplasty devices, meaning devices that were placed at the level of the coronary sinus, creating some tension at the level of the coronary sinus, and then reducing the perimeter of the mitral annulus. Many of them were abandoned. There were many coronary complications, especially obstruction of the left circumflex artery, and only one of them, the Carvajon system, is still alive, I would say, and with CE mark and with reasonable results, I would say. And then there are many direct annuloplasty systems, MitraLink, Cardioband, that have, I would say, promising preliminary data that seem to be even comparable to the mitral clip. I'm talking now about functional MR. However, the complication rate is a bit higher. Again, very preliminary experiences, but are much more complex procedures. I didn't have personal experience with these devices, but you see and you talk with the people with experience with these direct annuloplasty devices, and is a much more complex procedure than the mitral clip, and with more complications, like, for example, a stroke that we don't see after the mitral clip procedures, or very, very rarely we see with this kind of annuloplasty devices. Some centers are starting to think about combining these therapies with the mitral clip device in order to mimic again the surgery with an annuloplasty device plus an edge-to-edge repair. I think that this will come in order to improve the results associated with mitral clip, that even if the results of mitral clip in functional MR are reasonably good, I think that all the people in the mitral clip field knows that in general the results in functional MR are not as good as those in degenerative MR. And in order to improve the results and to get close to a surgical procedure, if we want to use the repair concept, it will probably be a combination of annuloplasty and mitral clip. This is what is there, and we will see a lot of probably development in the next few years outside the full valve replacement.
So therefore, it will be safe to say that besides the mitral clip, there are many other devices have been tried, particularly for being the mitral annulus near the coronary sinus. So indirect annuloplasty, put some device in the coronary sinus and tight it. So the posterior leaflet annulus comes closure, and then putting the ring actually percutaneously. There are various techniques have put a direct ring at the mitral level, but all those are very complicated and have gone just beyond a preliminary data and not really come down to a stage 2 and 3, which leads to the final most important topic, and that's, I would say, will be the horizon, is the percutaneous mitral valve replacement. Just like the total replacement of the aortic valve, there are also some chorda tendineae replacement and so, but key is that total mitral valve replacement. So before we go on to and hear from the expert, those who have done that mitral valve replacement percutaneously. We will ask Dr. Stelzer that while there are so many patients which we can think about, the aortic stenosis, even if there may be a low risk, intermediate risk, that, patients wants on their demand having a significant stenosis, but we know that TAVR valve works very well, and they could become a candidate. From Dr. Stelzer, from your point of view, if there is no other comorbid condition in a patient with a significant mitral regurgitation and degenerative MR, all those patients should get surgery at present. Is that a right statement or some modification?
That's a little bit oversimplification, but I think that's the tendency to do so. If there's not a contraindication to surgery, we can be kind of spoiled by having good results with the repair. Overwhelmingly, the repair rate's extremely high. Here in our institution, we get spoiled with that. There are situations where repair is not possible and replacement is used. There are places like endocarditis, for instance, where it's all destroyed. There are patients who've had previous valve replacement and you can't repair that. There are patients who've already been repaired, and the re-repair is an option, but it may not be a durable option, and the patient is already 70 years old. So you can say, well, that's probably not worth the trouble. Those kind of things come into my mind. I don't have an axe to grind that I have to do 99% repair. So I said, okay, maybe there are some patients that it's okay to replace. And it's also important to remember that the data from Mayo that showed that separation in survival curves of repair versus replacement, almost all of that was represented by the operative mortality. And it didn't get until about 10 years later that there was some significant separation further on. If you just kept the people alive when you got them out of a replacement, they did pretty darn well. So I think part of that was colored by the fact that people who got replacements had had 2 attempts at repair before they got replaced. And so there's a little bit of muddying of the waters in some of that data. But yeah, the bottom line of answer to your question is, if a patient is a candidate for surgery, we would offer surgery to those patients.
Therefore, the trials of valve replacement has to be, mitral valve replacement, the patients who are high risk. And that's where, of course, the repair completely goes out. Mitral valve, it will be a replacement. And there are 2 types of valves are being studied. One is our existing approved valves. One is the Malady valve, which we use for pulmonic valve regurgitation and second is the Sapien, which is used for aortic valve, and then you just change the direction and that implanted either transapically or some cases transeptal, so into the mitral position. But then there are dedicated, the mitral valves, which have some attachments, some hooks, so it stays at the level of the mitral, so do not embolize and so on and so forth. And we just need to hear from Dr. Cabal, the expert. Tell us about this field of mitral valve replacement. And you have been involved in many of these, some of these beginning trials that where this field is going to go.
The idea again is I think that we all recognize that with the MitraClip it will be very difficult to obtain result that would be close to surgery, and if we want really to get a result with either mild or trace mitral regurgitation, in many of these cases we will need to replace the valve, because unlike the surgeons, when we talk about, I was in France talking about transcatheter repair, and people talk like it was like surgical repair, and honestly it's not at all like surgical repair, even if we say repair. The concept of transcatheter mitral replacement, I think that is appealing in terms of obtaining a surgical-like result, but the complexity of the mitral valve and the complexity also of the patients, as you said very well, has made this field, the evolution of this field, much slower and not as rapid as the TAVR field. The problem is that if we want to do a fully percutaneous procedure from the femoral vein, we have to deal with very large mitral annulus, irregular, that is D-shaped, irregular anterior and posterior mitral leaflets, absence of calcium, unlike the aortic size. And all these features made this field very complex. As I said, because from the femoral vein, you need a transeptal procedure with a very big catheter. You need a big catheter that has to have flex capabilities to approach the mitral annulus properly, and then you need some kind of coaxiality in order to position your valve properly. Very complex, and this is why most of the mitral platforms up to now have been implanted transepically. Because it's a very direct way of replacing of implanting a transcatheter valve. And all these valves but one, at least the ones with human experience, have the same principle. You have to capture the mitral leaflets with anchors, with paddles, but the idea is really to have a ventricular retention for your transcatheter valve, and then you need a large atrial platform that gives you also stability at the level of the atrium. And this is all valves are different, but all have similar features in terms of grasping, capturing these mitral leaflets, and then a relatively large mitral atrial surface in order to have a good anchoring of these mitral valves. We talked this morning about the results of these with these mitral valve platforms. I would say that are probably even better than the very first results with TAVR, which is relatively surprising in terms of mortality rates, etc. The problem probably has been, at least for some of the platforms, the problem of valve thrombosis that has been rare in the aortic space. I know that there is a hot topic now, but clinically, the problem of valve thrombosis is really not there in the aortic field. But here we rapidly understood that we need to maximize the antithrombotic treatment when we implanted these valves. And then the last thing about implanting a fully replacement is, if we think about the future, if you have a MitraClip and then you have a recurrent MR, you can implant maybe another MitraClip, but you cannot really implant a transcatheter valve. You have sometimes even 2 or 3 MitraClips there. You are done. Either you operate on the patient or maybe implanting another MitraClip. If you have a valve there, you can do valve in valve at least once, maybe several times. And this is the way of thinking about all this process of starting with implanting a valve. You have already a platform there. And then with this platform, even going transfemorally, it won't be probably too difficult to implant a transcatheter valve through the femoral vein in a patient with a transcatheter mitral valve in place.
So can only do once. Just to say, overall data for the TAVR valve in most of the studies is about 2%, 2 to 3% valve in valve, means you require 2 valves for Edward Sapien trials, with a core valve almost 5%. Now, just to update you, at Mount Sinai, our number is less than 1% for both of them. Actually, for Edward is 0.4, but the core valve is about 1.2. So we are 1%. But here, clearly, that if you put one valve, it didn't work, that's it. That's the only chance. George, you wanted to comment on this?
No, I think the last point is very interesting, that the mitral clip with the new valves come up is going to be practically further marginalized for this very simple reason that if you put a mitral clip, then you don't have a chance later on to put the valve. So that would be a limitation, and it will be a distinct population treated with a mitral clip device. And no question why this device is not going to have many generations, because we don't see that the use is going to be so high with the advent of the new valves.
Yes.
I had a quick comment and a question. So I think one of the things that we see, at least in imaging, and I think Dr. Stelzer can comment, mitral valve varies from person to person. No single mitral valve is the same. Everybody has got some scallop, and it's extremely dimensional. It's like it's got a height, it's got a saddle shape, and so on and so forth. So when the surgeon opens up, he has the ability to see and adapt the stitching and all the techniques that needs to be done. So one size may not fit everybody if you have one design. So the question is, we'll have probably a battery of different sizes or types of valves for mitral valve, or maybe we will 3D print a valve in the future from the imaging. Every person, so there'll be a design that valve given person will have that will fit the patient. Any comments about that?
That will be the real future.
This is a very good point, and this is something that we regularly discuss with manufacturers of this valve. In general, when you start a program, usually it's very complex to have different sizes for different reasons, but in general, you have to pick up one size to start. And this is the reason why I think that was very clever to try to use these anchors, these paddles, these to really to fix the valve at the ventricular level by grasping the mitral leaflets, and then having very large atrial platforms in order to have like one single size that could be adapted to different anatomies. If you tried, let's say, like an Edwards valve, like in the mitral space, it would have been really a catastrophe because of this, different anatomies, etc. But here, really, the principle is rather than base your efficacy on radial forces or on anatomy and differences in anatomy, I think that the idea is really to take advantage of the leaflets of the patients that are variable, I agree, but in general, I think that with the mitral clip, we are also successful to clip to be able to have a good clip in most of the cases. I think that this is the way that the manufacturers have tried to overcome, partially at least, this problem of different anatomies. But in the future, we will need definitely different sizes for different patients. We didn't talk about the LVOT obstruction, that is a potential also problem that will need to be addressed with these new valve systems.
And actually, Samir had put it very nicely, the 4 valves, and compared to the tower valve, there is no attachment. It is just you expand with a balloon, it stays there. You have the calcium in the aortic valve. So all these, the new 4 valves, they have some kind of fixation system projecting into the atrium or to the annulus to really hook on. And so, Paul, you want to?
I was just thinking about we have a couple of advantages, a couple of disadvantages because of the anatomy of the mitral valve and the fact that we're addressing regurgitation as the primary lesion as opposed to stenosis. We lose the advantage of the calcium for stuff to grab on, like with TAVR, but we have the advantage of the dilated annulus that gives us more room to put a bigger device, a little more hemodynamically efficient device, and allows another valve in valve in the future. The attachment is definitely a problem. And, we put rings in people and kind of force the annulus into what we make it to. But, we recognize that not every valve is going to accept a perfectly circular ring. We maybe use a saddle-shaped ring in one or another, and we can also force the annulus in like ischemic MR to pull up one side more than the other with some of those crazy dog bone things and all that. But the one thing that we haven't talked about at all is the elderly patient with mitral regurgitation but severe MAC. And now we have a different problem And the fixation devices too, you know, now you start, every time you start pinching things or poking things, you run the risk of poking holes through things that you don't want holes through, or compressing things that you don't want to compress. You know what, Liz, but between the ventricle and the atrium, and you have a big thing smashed on either side, there's this little thing called the circumflex coronary artery back there. And we've heard that with stitches, just sewing in a valve. And I imagine we could probably hurt them with some of these devices too, if the fixation device penetrates that area. And maybe you could talk a little bit about how do you deal with a patient with MAC? And how's this technology going to affect that?
I can explain, for example, the first patient we did in our institution with MAC, and I remember talking about this in our weekly meeting and saying, no way, no way. And then first case appeared from Europe, from Germany, and a second case from France. And I said to the surgeon, it seems that it's feasible, because when you look at the mitral anatomy in these cases, and then you look at the valve you have for this, which is in general the Edwards valve, could be the Melody valve, but is sometimes too small. Your first thinking is it's not going to work. It's impossible. You have really a D-shaped annulus, severely calcified, and say this. But we have done up to now 3 cases. There is a gold-white registry, close to 100 patients that have been put together. And admitting that the mortality is high, most of these procedures are made transapical, etc. The results are relatively reasonable for this kind of procedure. There are complications. LVOT obstruction is a major one. 15% of the cases around have. But in some desperate cases, is a procedure that can work, even if it seems impossible. The valve, at least the Edwards and Melody valves, seem to adapt really to this anatomy. There is always some leak. It's not perfect. But in some patients can have benefit from this procedure, and these are patients that have no other option otherwise.
And that's where at present the percutaneous mitral valve, using the aortic or Melody valve, which is the pulmonic, is being used either bioprosthetic mitral degeneration or severe MSMR caused by the MAC, not necessarily by the leaflets. So that nor you can do a balloon valvuloplasty, nor they are good case for mitral valve repair or surgical mitral valve repair or replacement. And the percutaneous valve with the SAPIEN and the Melody valve are being used. George, you want to say something?
Yeah, I just wanted to clarify that in these cases of the MAC, we would forget about these designs, and we would go back to what we use in the aortic valve. I just want to make that clear. That's the answer to that. They're a little primitive at this point, but clearly these designs are not going to work for the reasons that Dr. Stelzer alluded to. But we revert to the other ones that work in the stenotic aortic valve.
And the SAPIEN is probably a better option than the Melody because it's not such a high-profile device. The high-profile Melody valve is the one where you get into trouble with the LVOT obstruction.
The Melody is both high-profile as well as long, as well as in the end of the day, smaller orifice. So all the ways it kind of doesn't match up well. The only advantage it has the cells are always covered, so it has a less chance for a PVL if there is because there's a depth component to the paravalvular leaks all the time, and if you have a completely covered stent, then have more chance to seal.
Yeah, so to sum up about the field of percutaneous mitral valve replacement, it's still evolving. They have early stages issues, which happens even with the Tower valve. If you recall, the Edward valve was recalled 3 times before went to the trials. So we have had a valve thrombosis and outflow obstruction. So there's a lot more we are going to hear in the future. Just wanted to take a few minutes because Dr. Goldman told me that we need to talk about the tricuspid valve. So I think the best way would be that just get your comment on which patient or your experience about the percutaneous tricuspid valve replacement.
This is if we talk about the transcatheter treatment of these valves, I think that is very appealing because probably the surgeons agree that patients usually with left-sided diseases, frequently valve diseases that have already had an intervention in the past, usually are very high-risk patients, sometimes with a relatively high in-hospital mortality. And there is no other option. The problem with the transcatheter treatment of the tricuspid valve is that the challenges that we are facing in the mitral space are even more important. The valve, the annulus is extremely large. There is a very tight angle with the inferior vena cava. There are potential problems with coronary obstruction, right coronary artery, coronary sinus obstruction. Many of these patients have pacemaker leads, etc. And this is probably the reason why there is no, up to date, no transcatheter valve that has been implanted, at least in humans. There are preclinical work that is being done with, there has not been any human case with a fully percutaneous replacement of the tricuspid valve. Then the technologies that have appeared are either to treat the reversal flow at the level of the vena cava, implanting valves at the level of the vena cava, either bicaval or in the inferior vena cava at the level of the atriocaval junction. There have been also annuloplasty devices, particularly the Mitraling, that is applied also to the mitral, and the 3-inch annuloplasty device that is a very is a device that creates some tension in between the vena cava and an anchor at the level of the annulus, trying to reduce the perimeter of the tricuspid annulus. And then there is a device trying to improve the coaptation of the tricuspid leaflets. It's like a balloon made of a polymer that is implanted at the level of the mitral valve in order really to improve the coaptation of the tricuspid leaflets. All the results are very preliminary, but I think that is in a space where we will see a lot of progression, because I think that the need might be even more important than in the mitral, with respect to the lack of any good possibility or good treatment for many of these patients. That, as I said, at least in our experience, was the case, that many of them had already an intervention for either a mitral or aortic valve in the past.
Yep. So I think these will be the cases. Refractory tricuspid regurgitation, despite every therapy, has a prior surgery, make them very, very high risk cases. And some of the techniques have been tried, as mentioned. And one of them, which is gaining some momentum because simpler, to put a stent, a peripheral stent at the vena cava atrial junction, and then you put a valve inside that stent. Because the limitation, the tricuspid annulus is so big, so we don't have any valve available at this time, so they're putting a stent and decreasing at least the backward flow of the vena cava. So many of the techniques are still evolving. One of the issues remain in United States is part of reimbursement. All these are experimental, so you can use it off-label indication, but then hospitals do not get reimbursed, but techniques are available. With that note, I think we just open this evening for any questions by our audience participation and any question about this field. Yes?
You might talk about this, and maybe I just missed it. Because of the imperfect or the geometry in placing the percutaneous valve, is there any concern for thrombosis? Is that something that's been addressed in the trials? Just the risk for thrombosis with the percutaneous valves.
I mean, that's for the mitral?
For the mitral.
Yeah, no, mitral actually, the total replacement of the valve, the percutaneous mitral valve replacement, the two important issues have come up. One is the valve thrombosis, which is rare in the aortic position, and second is the outflow obstruction. So valve thrombosis has been maybe perfectly just because of this purpose. We know in the bicuspid asymmetric aortic valve, we put the tower, we leave some more regurgitation, But there is rare cases of stent valve thrombosis. While with the mitral, actually there are 2 patients, the trial was halted because of valve thrombosis. So it does happen because of asymmetry, and knowing the mitral has a higher thrombosis rate anyway. So even surgeons, when they replace the mitral valve, continue anticoagulation for 3-6 months or longer. But with the aortic, they don't do it same. It will be more focus, will be on the mitral, the antithrombotic strategy in the mitral valve replacement.
I was just wondering if I can get everybody's thoughts on this. I'm still trying to get my head around how hemodynamically a valve in the IVC is going to help you for tricuspid regurgitation. We had this discussion a little bit earlier, and I know Dr. Sharma and I have had this discussion before. To me, it doesn't make sense in the sense that the IVC pressure is going to have to exceed the right atrial pressure in order for the valve to open. And so if you don't decrease the regurgitant volume with the valve in the tricuspid place, with the blood sloshing back and forth between the right ventricle and the right atrium, if you don't decrease the overall mean right atrial pressure, maybe you'll decrease the V wave that's reflected back to the liver. But I don't see this as something that's actually going to make a lot of sense. So I mean, I'm certainly open to the idea of a trial, and if it works, great, and everything else. But I'm a little skeptical. I wondered if other people might have some thoughts.
You want to comment, Dr. Kabal? Because we actually had a patient which was referred to us for this purpose, patient end-stage cirrhotic disease, and by the time we are discussing what to do, and so of course the patient had an adverse outcome without even coming to the hospital. But the key, these are the serious cases. We have very short-term lifespan unless you fix it. That patient was badly cirrhotic, and so the question is why just blocking this inferior vena cava, putting the valve should help.
Your point about the hemodynamics is well taken, and I think that is very pertinent. The reality thought is that the patients that have been treated this way, it seems that the valve opens properly, and that some of these patients really had important improvements in hepatic function and peripheral edema that are usually the important consequences, or maybe of severe tricuspid regurgitation. I agree that that is really a palliative treatment, but there is a lot of interest, and in fact, there, apart from a registry in Europe, I know that there is a feasibility trial here in US trying really to see the potential benefit of this treatment in a very selected group of patients.
Dr. Fuster?
No, just 2 comments about the future of these bioprosthetic valves, if you like to call it. First of all, about the thrombotic phenomena, which is why I'm in the microphone now. There is more and more evidence that the degeneration of the bioprosthetic valves is a significant thrombotic phenomena. And actually, you will see in JACC a paper coming out from the Mayo where they explanted the bioprosthetic valves, and there's a significant problem with thrombotic phenomena. Just to point out, the thrombosis in the bioprosthetic valve has not been recognized because there is no imaging technology that can really make you to recognize that. And now there is a new formula coming out with the gradients and so forth, which I don't have to go into it. And then my question, I take advantage of this comment made in the back, but how do you see the future of these valves in terms of the degeneration process? Because it's so recent, everything
Extremely recent. You talk about the mitral platforms. We don't know. We don't know for example.
No, I'm talking about the aortics, the mitrals,
Okay, overall. Well, aortic, I think that honestly, when the 5-year follow-up of the Pioneer trial came out, I think that we were all very pleased seeing that the gradients were similar or even better to the surgical valves. Pleased to see that there were no major structural failures of the transcatheter valves as compared to the surgical ones. I think that in the aortic field, the data that is coming and is randomized data is very, I think, reassuring. We have not 10-year follow-up. Most of these patients will die probably before 10 years, but still I think that these valves seem to be, at least at 5-year follow-up, the data is reassuring. For the mitral space is a very different thing. There are some patients now at 1 year, over 1 year, and the valves are working well. But your point is important. We have also some preliminary data showing that maybe the absence of anticoagulation may favor increased gradients in transcatheter aortic valves. And I didn't know about this paper coming to Jack, but I think it's a very interesting hypothesis of thrombotic mechanism starting the degenerative process.
Just to most of the data now, at least for the tower, we have 5+ years, few thousand of patients, and the valve degeneration is about 3 to 4%. So similar to will be a bioprosthetic aortic valve. So which we know, but clearly we know that degeneration truly starts 7-10 years later. So we are not there yet. Dr. Zaks?
Carl Stengel at the University of Berlin is doing transcatheter replacement of the pulmonic valve and the inferior vena cava. The superior vena cava is usually not necessary, but the inferior vena cava valve is very important if you're planning on operating on the abdomen for carcinoid in particular. If you have right heart failure, you must fix the heart first. And so this can enable a patient to get the pressure relief so that it's safe to operate on the liver or other areas in the abdomen.
Absolutely. Point very well taken. So that's just a decreasing pressure on the inferior vena cava may make these patients hemodynamically better in these refractory patients. If there is no other questions, I really thank all our participants and of course the panelists and our visiting professor for excellent evening, and thank you very much.